Good afternoon, everyone, and welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for today's session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email, address, and affiliation in the chat box. Please stay muted unless you are speaking. You can use *6 on your phone to mute and unmute, or you can use the microphone icon on the bottom left-hand side of your Zoom screen. You may also use the chat for communicating. If you do unmute your microphone, please announce yourself before you begin speaking. We realize that question and answer time is important to you, and we're trying to categorize and address as many questions as possible during the sessions. But if there are any open items afterwards, we'll always follow up via an email. If you have suggestions for future COVID-19 Echo topics, please share via the chat tool or email us at echo@psu.edu. Please remember that when we discuss cases, no personally identifiable information is allowed. We are recording these sessions, and we share all materials and recordings after the session. In the spirit of all teach, all learn, we'll be on a first-name basis during the session. For those of you who are new to Project Echo, our Echo sessions always begin with a brief lecture and are followed by either a case discussion or Q&A. Cases can include a question, challenge, anything that you would want to address that would be a critical issue or challenge, and we would generate ideas and discussion around that. You always receive a link to submit cases in follow-up emails. Today's session will include a brief lecture and a case on the importance of the 4 M's during the COVID-19 pandemic, and that will be by Jenny Knecht Fredo and Dr. Heather Young. I'm sorry, Heather, I didn't have your name listed here. Dr. Heather Young, and then we'll follow that with a question and answer period. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from both Penn State Health Online and a team who is already working with the 4 M's through other projects, and they will help to field questions. But remember, this is all teach and all learn, so everyone can share both questions and answers. And we'll pause after the lecture in case and address any questions that come up. With that, I'm going to turn things over to Heather and Jenny.
Okay, hello everyone. So my name is Jenny Knecht Fredo. I'm part of Age Friendly Care PA, which is a collaborative with Penn State College of Nursing and Primary Health Network. We're a GWEP, a geriatric workforce enhancement project. So our goal at this time is to basically enhance the care of older adults in our community. Heather, are you on here?
I think she is. I did get a message from Donna that she was on, but let me scroll through.
Thank you.
But I'm not seeing her, so perhaps she got disconnected.
Okay, so I will start with Heather's case, and we'll let her finish at the end. So I want to touch on this short case study. I think it's important to see kind of what is going on with our older adults right now. So Amelia cares for her parents who live nearby. Her father, Samuel, has dementia and develops a dry cough, a fever of 100.8 degrees, shortness of breath, increased confusion, and agitation. Amelia and her mother, Sarah, take Samuel to the local hospital, where he's met at the door by staff, dressed in masks, gowns, gloves, and face guards. He's swept into the emergency room, screaming at Amelia to take him home. Amelia and Sarah are told the hospital has restricted visitors and they must wait at home for an update. They leave, distraught and worried about Samuel. Amelia is concerned about her mother's health, about potential transmission of the virus to her family. They returned to Sarah's home under state orders to shelter in place, at a loss for what to do next. So what do we know about COVID in older adults at this point? Older adults are twice as likely to have a serious COVID-19 illness. As immune systems change with their age, it makes it harder to fight off diseases and infections such as COVID. Older adults also tend to have more serious chronic medical conditions that put them at even higher risk for getting sick from COVID. So now more than ever, we need to be checking on our older adults. So what a great way to use the 4 M's at this time. So the 4 M's are a national framework by the Institute of Healthcare Improvement and the John A. Hartford Foundation. The 4 M's can help support strained health systems by providing evidence-based care to our older adults. Simply put, the goals of the movement are to provide best care, prevent harm, and do what matters and what satisfies our older adults. It can simplify and reduce implementation burden, and it focuses on the core health issues of our older adults, which we consider the 4 M's: what matters, medication, mentation, and mobility. So what exactly are the 4 M's? I'm going to dive a little deeper into this, but age-friendly care is a reliable implementation of a set of evidence-based geriatric best practice interventions. So when we look at what matters, we're going to focus on aligning the care of the older adults to their specific health outcome goals and care preferences. This can include, but doesn't have to include, end-of-life care. When we focus on medication, we're going to be focusing on deprescribing and avoiding high-risk medications. And if we have to, make sure it doesn't interfere with what matters to the older adult. When we focus on mentation, we're going to focus on preventing, identifying, and treating dementia, depression, and delirium. When we focus on mobility, we want to make sure our older adults are moving safely every day and maintaining function. So how can we adapt the 4 M's to fit our current needs right now? Right now, there are essentially 2 ways we're seeing most of our older adults or contacting them. We're using telehealth frequently, and we're getting education materials out to our community members. At this point, face-to-face conversations aren't happening as frequently. So I want to address ways we can use the 4 M's differently than how we're using them at this point. So that can be with medical visits via telehealth or wellness checks. Education materials are also a great way that we can reach our older adults, and we can get them to our older adults via things like the food banks around us. Oops. So why telehealth? Telehealth promotes the practice of social distancing, which we know is extremely important right now. In order to by social distancing, we're going to limit the physical contact between staff and patients. And we're also going to reduce the risk of the spread of COVID to our healthcare workers. We're also going to reduce the risk of exposure. So because our patients don't have to come in to see us, they're going to reduce the risk of exposure via public transportation and via high volume or high traffic areas such as waiting rooms. So is telehealth bad? I mean, I don't think so. I think it helps us in many ways. It helps us to explore options for continued care for those who are most vulnerable, such as our older adults, but it also expands our reach to community resources that we may not have available. So mental health professionals in this area are really hard to find. The use of telehealth can improve our reach of resources tremendously, and other specialists. But also, this is a cool thing about telehealth that I didn't really think about, but it gives us the opportunity to see our patients in their natural environment. So we can see them getting up from their own chair. If they have a chair that may be too soft, and it may be more difficult for them to get up than a chair that we would see in the office. We can also see where and how they store their medications. I work in a lot of homes, and I see a lot of older adults that when I ask them for their medications, they give me this pile. It's not organized at all. So we can see how they're taking their medications or storing them. And we also can see clutter. So these kind of things, we can put them more at risk for falls or mobility concerns. So one thing with telehealth that can be more concerning is the setup of the telehealth. So it's been studied that more than 1/3 of older adults don't feel comfortable using technology. So the setup is very important. Calling the patient before and making sure they can practice with the camera or practice with the microphone before your visit will lead to a better visit. Assuring they have all equipment within reach during the visit can also be very important, such as hearing aids, glasses, a paper, and a writing utensil. So I'm going to focus on how we can assess and act on each M throughout the rest of this presentation. And I am going to give scripts. I'm going to talk in a script for each M in order for you to feel how the conversation would go with the older adult. So assessing what matters. We want to explore how our older adults are doing with the stressors at this time. We want to ask them what matters. And for older adults with more serious conditions, we want to consider asking them what their goals would be if their health condition worsened at this time. Advanced care planning may need to be altered at this time or initiated. So let me give you an example. Hello, Mr. Smith. My name's Jenny Knecht. I'm the nurse at your primary care office. I'm calling to check in with you right now. We know it can be a stressful time with the coronavirus limiting our abilities to get out, interact with others, and I wanted to know if you're doing okay. How are you doing? Many people are scared and anxious at this time, so I want to reassure you that our practice is here for you and continuing to provide the best care possible. In order to do that, I need to know what matters most to you at this time. So after we assess what matters to the older adult, we want to act on what matters to the older adult. Providers and healthcare saying things like, thank you for sharing that with me, Mr. Smith. Knowing what matters to you allows us as a team to maximize your care plan, meet your needs, and address your concerns. We want to assess medications by reviewing the medications with the older adult. They can show you the pill bottles and tell you exactly how they take them, and then making sure we're addressing any refills that they may need at this time. Refilling for 90-day supplies at this time is also a good practice in case they would not be able to get out of the house for a period of time. Specifically, we want to look for benzodiazepines, opioids, high anticholinergic medications, over-the-counter and prescription sedatives or sleep medications, muscle relaxants, tricyclic antidepressants, and antipsychotics. So you can say to Mr. Smith, okay, thanks for that. So let's do a review of your medications. How do you organize your medications? Can you show me each of your pill bottles? Tell me how you are taking it and what it's for. If not, if he can't tell you what it's for, talk with him about that. Use this as a learning opportunity as well. So also make sure he has enough of his medications. So after we assess medications, we want to act on medications. So deprescribe or not prescribing during your telehealth visit any high-risk medications, such as those that you just saw. And if they do take one of the high-risk medications, discuss any adverse effects they may be having and discuss deprescribing. They may not be on board to deprescribe at this exact moment. However, just talking about it may lead them to be on board with deprescribing at future visits. So you can say things like, okay, thanks for that, Mr. Smith. Sorry, one second. If you need refills on anything, let me know, and we'll get them called into the pharmacy. Most pharmacies are offering delivery services at this time, and that it may be a great time to talk with him about that in your area. You can also thank him for completing such a thorough review and see if he has any concerns regarding his medications. You can say things like, I see you're taking oxycodone for pain. This medication can cause some concerns and adverse effects. Continue and discuss deprescribing with him. So when we're assessing mentation, we want to allow them to express how they are feeling regarding memory, stress, and coping mechanisms. We want to screen for dementia, screen for depression, and screen for delirium. If you don't have a specific tool you're going to use via telehealth, the mini-cog can be used if you have video capabilities, and the MOCA has been validated for remote use. You can use the PHQ-2 to screen for depression remotely, and the UB2 to screen for delirium. So you can say things to Mr. Smith like, now this can certainly be a stressful time, and sometimes under stress, we have difficulties with our memories, including short-term memory. Have you had any episodes of forgetfulness or confusion lately? And then you can make sure that you're letting him know that you're going to be testing his cognition or his depression or delirium before you provide him with the testing. When you act on mentation, you want to make sure that you're sharing the results of all your screenings with the patient and the family right there during your telehealth visit. You can provide support and resources with them, such as the Alzheimer's Association website, or consider referrals. There is virtual counseling available and mental health counseling available, or you could consider starting on a pharmacological treatment at this time. But make sure you're acknowledging any concerns they may have or any factors that may be contributing to the depression. When we're assessing mobility virtually, you want to assess how they're getting around their home. Have them stand up, walk around, ask if they've had any recent falls, and see if they have an exercise regimen, just like you would in the office. You can use the timed up and go virtually if you have video capabilities, and make sure you're setting some goals with them as you're talking through this. So now I would like to talk with you, Mr. Smith, about getting around the home. Have you had any falls in the past week? Are you able to stand from the chair without help? If so, can you do that right now? Any dizziness or lightheadedness? When we act on mobility, we're going to ensure safe mobility for the patient by assessing and managing factors that may reduce mobility. This is such a cool time during telehealth to be able to see them in their environment. You can see if there are rugs or clutter on their floors that may reduce their mobility or increase their fall risk. You can refer to home PT services at this time and make sure we're supporting their daily goals. So set a plan with them to exercise every day. So you can say, Mr. Smith, just standing from your chair without using the arms of your chair is called a sit to stand exercise, and that can help your leg muscles getting weak. Try this. Try standing from your chair 5 to 10 times, 3 to 4 times a day, and walking 10 minutes around your house at least twice a day. Set goals with them now and address them later. So not only can we help by using the 4 M's in telehealth, but we also can provide the 4 M's in an educational format or in an educational material format to our older adults within the community. So we want them to focus on the 4 M's themselves by having them identify their own vital connections, keeping in touch with the ones they love daily, and continuing to do what matters. One other thing while focusing on what matters is we want them to figure out who could provide them with care if their caregiver would get sick at this time. In regards to mentation, they can take breaks from the news, considering only tuning into the news 1 to 2 times a day and focusing on activities that bring them joy. And if they need somebody to talk to, using things like the disaster distress hotline or the Pennsylvania helpline. When focusing on educational materials for medication and mobility, we want to make sure they have enough medications, make sure they're staying in a routine to take their medications on time, and eating their normal meals at normal times. And making sure they have certain over-the-counter medications available in case they would get sick. This includes fever reducers, cough suppressants, and tissues. Making sure they're getting outside when they can. Just because we're socially isolating or physically distancing doesn't mean we can't be outside. And making sure we're staying as active as possible. If they're new to exercise, there's so many online free exercise programs, and here's the goforlife.nih.gov is a good one for them to try.
So Jenny, I'm going to interrupt a second. Heather was able to join us.
Wonderful. Hi, Heather.
She was having some technical challenges getting in, but she is in. And I've asked her to briefly go over, excuse me, the case so that she can bring everybody up to speed before she goes into what happened.
Perfect.
Go ahead, Heather.
Thank you so much. I'm so happy to join. And it's always ironic when you're dealing with telehealth and you have a technological glitch. So I'm sorry about that. I'm not quite an older adult yet, getting there, but I'm sorry that I missed the first part of the session. Thanks for letting me join.
Glad you're here.
The case has to do with a family that's living at home with a person who has dementia, Samuel. And the family notices that he has a fever, he's having some difficulty breathing, and his confusion is really quite markedly increased. And this is a common thing when someone has dementia and then gets delirium on top of that. And with COVID, it can be one of the early signs that there's something going on for someone who has cognitive impairment and someone who's older who may not have an elevated temperature. So they were very concerned when they saw his change in mentation in particular, and then also his other symptoms. So they rushed off to the hospital. And what they experienced as a family is something that many people are experiencing now, which is the very sudden change in their relationship, in that they're not always allowed to accompany the person into a hospital. And that's something that's particularly difficult when you have a family member who has dementia or special needs that may not be understood easily by staff who don't know the person. So very distressing for family and also very distressing for the patient as well. So in this situation, the mother, the wife and the daughter were very suddenly parted from Samuel and had to go home. And of course, we're very worried about what happened to him and whether he would be all right, and then concerned about their own health in case he did have COVID-19. So what happened with this case was Amelia, the daughter, got a call from the hospital and that he did test positive. And they did ask about his advance directives. And fortunately, this family, and this goes into what matters, what Jenny was talking about earlier, one of the things that matters to this family is they thought about his end of life and they had an advance directive. So Amelia was able to say, we've got this plan and we'd really appreciate it if he has no heroic measures and if we could arrange for him to come home. they both thought, well, we've already been exposed. They did have some mild symptoms, but they figured it would be better to bring him home and be with him and take that risk. So they brought him home. And with hospice, they were able to care for him at home, and he was able to have his last days with them. And that was really consistent with what matters to all of them. And so he died at home peacefully, and then they actually slowly recover from their illness, and Amelia is able to return home to her young family. It was actually her decision to not go home to her young family after she took him to the hospital, because she realized she's probably been exposed, and she didn't want to take the bug home to her family as well. So she essentially quarantined herself at home with Sarah. So in this family, that you see a lot of very complex dynamics. So the need of the older adult, the partner who's also older and has some health conditions of her own, and then the family considerations as well. Thank you, Jenny.
Thank you so much. I'm glad you're on.
Too.
And so I just have a set of questions that I think we could consider within our group and see what we're doing and how we're using telehealth and using the 4 M's within telehealth. Jackie, do we want to see if there are any questions first before we go?
Yes, and actually we have a question and a comment. Let's start with the question first. And certainly if there are other questions before we move to the consideration ones, please feel free to enter them into the chat or to unmute your microphone. So Deidre, when you were talking about telehealth and being able to see the mobility of the individual, what do you do if they fall while you are assessing that via telehealth?
You know, I don't think I can answer this. I've never had that happen. But I think seeing what they can do to their ability is always what you want. So if they aren't walking at all, you don't want to ask them to walk. But doing what they can do to their ability, I think, is where you want to start.
And I think Heather said she can add on to that. Heather, feel free at any point to do so.
Thanks, Jackie. So if you go to the ARP website, we actually developed a video that it describes how to help someone get up, how to assess a fall and how to get up from a fall. And it's if you go to Home Alone, the ARP website, and look for videos, Home Alone videos. For a health provider, it helps you to see how to coach someone through this. And it coaches them through assessing whether there's an injury, and then helps them to figure out how to crawl to a stable piece of furniture like a large couch and help them to get up. And I think that's it's important to have some kind of an idea in mind about how you would manage that if that were to come up. And the video is a very good, obviously you couldn't use it with a person who's just fallen, but it's certainly a video from a preventive point of view and from a provider point of view that helps with the tips.
If you could share the links for that with Jenny, she can get that to us and we'll put it in our resources.
I'll do that.
Thank you. And Donna is asking, she sees several people from the Johns Hopkins group on the call and is wondering if anyone from that group has suggestions for telehealth measures for mobility goal setting and measuring progress.
Hi, I'm Deirdre Johnston. I work with Mind at Home at Johns Hopkins. And, you know, to me, telehealth has always seemed to be the way to go with these patients. They shouldn't be driving, they shouldn't be traveling, and they're often at home alone. We want to keep them out of potentially hazardous environments, especially now. So in Mind at Home, we actually went into the homes and did assessments and determined what they needed related to their dementia, did a walk around to see what were the hazards in their home. Obviously, that's more difficult if you're trying to do it via telehealth. It does help if there's a family member there. And so, you know, it makes everything much easier if there's a family member there, obviously. So very often, you know, if you're going to do a mobility assessment, obviously you're going to first screen for previous falls. You're going to want to know where they fell and how they fell. If it's safe, I agree with Jenny. If it's safe, then you want to be watching very closely and carefully and have a backup plan. There may even be a consent issue involved in getting them to stand up, particularly if there's nobody there with them. So I would think very carefully before asking somebody to stand up. If you have a caregiver there, then you can involve them, have them stand, coach them through what you want them to do and where you want them to be. And to be honest, I would be a whole lot more comfortable asking a person to stand in the presence of a caregiver, even though I can see the value of, particularly if somebody lives alone, because they're at high risk of seeing for yourself how they are. One of the things that we do when we do telehealth visits is, particularly if they've had falls, we'll get the family member to walk around the house and show us where they fell with the device they're using. And that gives us a virtual home tour, so that we can see what's happening and we can coach them through ways of making the environment safer. So that's one of the, if you have somebody there, there's a whole lot more you can do. But thanks, this was great. And I love the 4 M's, they're wonderful.
Thank you for providing that input. I do want to go back. Donna had made a point earlier on delirium and delirium superimposed on dementia as a common sign in older adults, and that can have atypical presentations with no temperature, and that this has come out in some early COVID observational data. So I don't know if anyone has experience with that, questions or comments around it. So again, please feel free to unmute your microphone or put any questions and comments into the chat. And if not, Jenny could take us through some of the questions that she's been dealing with.
So some of the questions that I have, for those of you that are doing telehealth, are you addressing advanced care planning with them? And if you are, how are you documenting these conversations? Are you having them come in or sending them a post form, or how are you putting this in a form for the hospitals to be able to use and to transfer the care planning? Or if you aren't doing this, how could we?
And I don't want to put people on the spot, but I often do. Andy, I know that you're online, and I don't know if there's anything that you can contribute to this. Any input?
Yeah, so we have been trying to address some of these issues with our palliative care population, which not all of them are elderly, but all of them are vulnerable, obviously. So I think trying to work on some scripting around how to talk about these issues and making recommendations, both in terms of advanced care planning, but also talking about some of the statistics you mentioned for older adults. And a lot of people are interested in having us address these matters with them and their family members if they're available. And a lot of times we end up documenting this in our EMR, but I think the comment about post forms and things that way, I think are good things to think about during this time. It's a little more challenging if you're not physically there with somebody to get a post signed, but I have seen posts completed with family members remotely in the past, and actually documenting them as giving consent via phone as opposed to physically signing the document. I think one of the echoes we've had in the past about communicating with people is another important point of, people are looking to have these conversations, especially about end of life, and they want our opinions about how they should think about getting treatment if they think they're infected with COVID.
Thank you, Andy, for sharing that and for allowing me to call you out on it. I appreciate it. Are there other questions or comments around that before we move into some telehealth technology questions that have come in on the chat and on my phone? All right, so Bill wants to know, how do you get older patients to use the technology for telehealth? Is it a challenge getting them not just on board with the physical, but mentally on board for that?
So physically using telehealth at this time, I'm a hospice provider. So I'm actually we have our nurses go into the older adult's house or the patient's house, and they bring iPads with them. So I'm telehealth, but all of our older adults that I'm doing telehealth with have a nurse present with them, which makes it much easier for the older adults. So the buy-in from the older adults, we don't really have that as much in my situation. And for the other, another position that I have, we're using FaceTime for visits, and they can use FaceTime if they have an iPad or a Apple cell phone. And for the most part, the patients are wanting it. So they want to do the videos. It's the making sure they're checking in first with my nurse will do it. My nurse will call in, make sure they feel comfortable, make sure they understand what's going to happen during the visit. And then during the visit goes much smoother.
Thanks, Jenny. Does anyone else have experiences with how to, orient an older population with telehealth? So I do see that at Johns Hopkins, yes, they're using iPads with cellular service. Many don't have Wi-Fi. So a few questions came in on my phone because connections were dropping. Who is facilitating telehealth technology? Are there voids or needs not being met that are preventing visits on the patient end? And I don't need you specifically, Jenny, to address that. Does anyone else have any input, especially if you've been dealing with telehealth in general? Please go ahead, George. Thank you.
Okay. Hi, can you hear me?
Yes, we can.
Okay, hi. So in the F2HC world, we've actually been opened up to allow even audio only visits can be considered a billable encounter. And for many of our elderly, when we initially tried to connect via Zoom or other platforms that they needed to download, it created such stress and anxiety for them, as we had a person trying to coach them through how to download. So in this particular group of patients, we've actually really been relying a lot on audio only, just a phone call. And our feedback has been that they love it. They're isolated, they're lonely, and just being able to make a connection with somebody that is compassionate and cares about them, just making that connection has been therapeutic. In those instances where the provider feels that they really do need to have a visual component for the assessment and in order for them to be able to manage their care, we have tried all sorts of things: FaceTime, Duo. We actually have purchased some licenses for Zoom and are trying to get patients to download Zoom. In the rural parts of the state that we serve, however, internet connectivity is obviously a challenge, and if we're unable to do it, we just rely on an audio only content.
Thank you for sharing that. Yes. And Donna indicated that she believes that if they cannot do video, that CMS will also pay for phone visits. So there are a couple of other questions. One comment that came in from John involved regarding the use of telehealth and the challenges involving grandchildren and children. And I'm assuming that works in good times, but maybe not in bad times. Can anyone provide any further insight on that and when that might work? Okay, so let's move on. If anyone has some thoughts on that, feel free to put them into the chat. So Donna wants to know, are there any innovative approaches to the restricted visitor policy? Donna, do you mean for hospitals, for nursing homes?
I think for both, I've heard in someone chatted in, I've heard stuff about using FaceTime and using through the window, but really what I was thinking about was particularly people with cognitive impairment, or there's some situations. So I'll give an example. During the 1990s, during a lot of what we're learning from COVID, we can look back historically at things like the HIV/AIDS epidemic. And at the time I was working as a nurse in California. And for those individuals, there's no way we could have done the care that we had if they didn't have caregivers at their bedside. So I wonder if there's been any policies, particularly people with cognitive impairment, that restriction has been modified, or again, if they just have innovative ways for addressing that, where it can be really critical if they don't have that individual at the bedside that they're normally relying on to be able to even do simple procedures in acute care and long-term care.
Thank you for that, Donna. So Lisa did mention at her hospital with the restrictive visitor policies, they're using FaceTime with families, visiting through the window with signs, and allowing for delivery of small items to the front desk to be delivered to patient rooms. Are there any other strategies? Anyone else doing things of that nature? And Donna shared a resource on information on how to have modified telehealth regulations and expanded care with phone and video. We'll make sure that that URL is in your resources later. And Jim Hayden has mentioned that at his facility, they attempt video and audio, but accept audio alone. And for FQHC's payment, audio alone is uncertain. But they do try to, when possible, get children and grandchildren to assist with telehealth. So other questions or comments? If not, I'm going to ask Jenny if she would go on to her second question about alerting patients to protocols.
This is Heather. I'd just like to add the issue of social isolation is really important and relates to the M around mentation. And for many people, encouraging them to connect and encouraging families to connect with the older adults is a really important element right now. There are also some robust organizations going on through different entities in neighborhoods, trying to get neighborhoods to connect and to allow people to make those human contacts from a physical distance. And in local communities, I think it's really worth looking into what's going on in your own community around that to help to identify who are the isolated older adults, because that's another element that's going to really affect their health as this goes on, is the social isolation, whether it's through telehealth connection or other types of connectivity.
Heather, I think that's so important. This is one of my questions I had actually. We've been setting mobility goals with our older adults for years. Every time I see an older adult, I set a mobility goal in the office, but very rarely have I set social goals. And I'm finding that should be something I should be doing at this time, every time I talk with them. But like, what kind of social goals should I be setting? Should I be saying, hey, make a list of all the people you love and call one of them every single day? You know, what are other people doing in regards to social goals right now? Learn how to use FaceTime or Zoom.
Yeah, I think it's engaging the family as well, to the extent that there are people involved, but also having the older adult talk about who's important to them and help them problem solve. How could they connect?
Yeah.
And maybe it's not every single day, but on a regular basis, making some connection with someone that they care about. Many people are good at writing, and maybe they would like to write to someone and re-engage in written form. I mean, it's really about the person's preference and their abilities and what they like to do, but to really encourage that to happen and to be more active about seeking it out.
Lex has a point. Lex, would you like to unmute your microphone? I know you've been on before and are familiar with our sessions.
Are you able to hear me?
Yes, we are. Thank you.
Okay. Yeah, just the isolation aspect of this is, it really strikes home. We had an uncle down in Tampa last week. He was in the ICU, and my aunt was unable to, be with him, to go into the hospital to visit. Also, he did not have his glasses. He didn't have his cell phone. He's, he's in his 70s, but he's very tech savvy. This is a guy that goes on the internet. He looks up things. He likes to be involved in his care. And not only was he unable to see, he was unable to communicate when he wanted to. And I think this is just something that I understand the challenges that the hospital's having, but these are small items that could have been easily disinfected. And my aunt was more than willing to either drop them off at the front door or FedEx them to them. And unfortunately, they did not have a process in place to make these accommodations. And I think it's something that would have really made a huge difference in his he was starting to suffer a little ICU delirium, and I think these things would have gone a long way towards alleviating that.
Thank you for sharing that. You bring up really great points. I don't know if anyone has comments or has experienced that or solutions to that. While you're thinking on that, Donna mentioned that doing a family conference call once a week is a good way to connect those who are apart, and it's a low-tech way. And John is saying when relatives are already involved, grandma might need to learn cell phone and FaceTime to communicate with grandchildren. So, all right. Any other questions or comments around social challenges during this?
Yeah, this is Janice Whitaker from Penn State College of Nursing. I recently had a good college friend with frontotemporal dementia who her sister was allowed to be present as she was declining in her assisted living facility. But some of the things we did as friends and family were sending we did kind of a letter writing and card campaign. And so the staff, as well as her sister, read those things to her on a regular basis and reread many of them. We also did some little video clips that were sent to her sister on her iPhone, and she played those for her, which, so she got all these wonderful, loving messages from friends and family in that way. And I know some of the things we did in our facility with people living with dementia were, suggesting to the family that they create a photo memory book and put some simple explanations of, who the individuals were or maybe the activities they were engaged in. And that helped to facilitate conversation and reminiscing, which can be valuable things as they're isolated by themselves, so that the staff can help to share in some of those experiences with them.
Thank you for sharing that, Janice.
I know, I have one more thing I can share.
Go ahead.
No, I have been really trying to talk with family members to send pictures if they have the capability to their grandparents or whoever it may be. I personally I have 11-month-old and a 2-year-old, and if I do not send a picture every single day to my great grandparents, they're messaging me, telling me that's the only thing they look forward to every day. They don't care if I talk to them on the phone. They just look forward to that picture of those girls every single day. So pictures can brighten a lot during this time.
Thanks for sharing that. Nice reminder. So KMM7 is saying an elderly brother in assisted living has a flip phone with very few minutes. They haven't been able to phone talk. So now they write letters to him and include self-addressed stamped envelopes so that he can send letters back. That's a great idea. And John is posting on the cost effectiveness of an iPad and Logitech keyboard, about $500 to $600, and reasonably easy to use, linked from almost anywhere to the world, cheaper and almost as effective as a simple laptop. But I still think a stamp and a self-addressed envelope has that beaten. But thank you for both of those. Great input. Other comments or questions? So Jenny, I know the second question that you had on your consideration points, you're talking about alerting patients to protocols, and I'm sure that that's not unique to elderly, but in the scope of elderly patients. Do you want to pose that question?
Yeah, so how are other practices letting our older adults or patients in general know that they aren't seeing wellness visits at this time? Are you actually calling every single patient? Are you sending out letters? Is it working? So I'm asking this for, advice, but also I recently had wellness visits for my daughters, and they had all of these rules, but we never knew. They never sent us any information before we came in. So it was surprising to me that they had rules, but we didn't know about it. So how can we better prepare our older adults for visits if they do have to go in?
So is anyone able to share strategies that you're using at your locations? I don't know if Jim Hayden is still on the line, but I know that in the past you've shared some of your protocols with us. Is there anything specific to the older population that you may do differently?
The older population, actually, when you're reviewing the protocols with them, to be quite honest, at times they're more astute than the younger ones, in that they recite back to me the issues of, we will call wherever we're going first and make people aware. And I simply review what they have, or what we have with them, or if they're impaired in some way, whoever is accompanying them. But for the most part, they're, from my perspective, at least the group I'm dealing with, they're better tuned into it. So.
Thank you. And thank you for allowing me to put you on the spot. Bill is questioning, should there be a section in the newspaper that's addressing these issues? So I guess something that is more visible.
We just actually were interviewed I don't remember whether it was Friday it was. The days are kind of running together with all this sheltering stuff and everything. But actually, it was Friday. We were interviewed by the local reporter, and she actually did an excellent job of running down pretty much all the points we made with her. And we went over basically, Jackie, all the protocols that we had put together. And she laid it out in most of, I don't know whether it was the front page or what, but she laid out most of it on a page and a half. I was amazed how much she put to it. So.
That's good to know. Thank you. And it's a good strategy to get that information out there. Donna mentioned, and she's going to share this video with me and we will get it to you, or a resource, a project by a practicing NP in Hartford found that even a 1-minute video with a family member or significant other used in acute care decreased hyperactive delirium and was able to calm the older person down. So we will make sure you have access to that resource. So we are getting close to the 1 o'clock hour. I want to make sure that everybody's questions have been addressed, or if you have any other suggestions or input to share with others, please feel free to put it into the chat or unmute your microphone. And while we wait for any more questions to come in, I'll go through our quick closing points, but we'll come back and make sure there's nothing in the chat afterwards. So please remember that you're able to collect CMEs for today. A survey is always sent following the session, and you can complete one survey for every session you attend. Using the same link is also what you would need to do. As mentioned earlier, we will be sharing all of the materials and the recording, and we hope you join us for the next session. I believe that there is a session on Wednesday, tomorrow, from 1 to 2 on managing mental health during COVID-19, but this is Resources for Family, and it's our Spanish version, so it is conducted in Spanish. And then on Thursday at 12, we discuss COVID-19, lessons learned, telemedicine in primary care. So maybe that will be addressing some of the questions we've been hearing today as well. If you have a patient case or question on the topic, please let us know and watch your email for future sessions. I'm just going to take a quick peek. I don't see any other questions. Any questions from the group?
Hey, Jackie, this is Erica. Can you hear me okay?
Yes, I can, Erica.
I've kind of been really quiet and shy because I feel like what I have to offer may or may not be useful in this context. But, you know, one of the things that I'm noticing is that with the social isolation is also, you know, there can be the boredom factor, right? And so trying to connect people perhaps with local volunteer organizations, or, you know, the area agencies on aging are usually pretty well tapped into various volunteer organizations that exist. So, you know, civic engagement is always an option to suggest, maybe for people who haven't thought about volunteering or being part of something that's nonprofit.
Thank you, Erica. All right, well, with that, I'll give you 3 minutes of your day back. Thank you for joining us. Thank you, Jenny and Heather and everyone else who contributed today. We appreciate it, and we'll see you again.